Hello, I'm Abhishek Ranjan of Policy Metrics, and today we are going to have a discussion on the issue right to health, making healthcare accessible, available, and affordable. So, our moderator Anu Bhuyan, who is a health reporter with India's Friends, she is going to start with the presentation now. Thank you. Over to you, Anu.
Hi, everyone. Good evening if you're in India. And my name is Anu. I work health journalist at India, which is a data journalism initiative, and I'm based in Delhi. I've been covering health for a couple of years. Before this, I was at The Wire and then Outlook magazine before that. So covering healthcare for a while. And now, of course, I am only covering COVID-19, not even healthcare in general, just COVID-19. And I expect that people can soon start calling me Dr. Anu because I feel like I know a lot. So that can happen soon. And today, the topic of this discussion is on the right to health, making healthcare accessible, affordable, and available. And I'm just going to introduce all of the wonderful people we have today. And Abhishek, has everybody joined? Is everybody actually on the WebEx right now?
Yes, yes, I think so. Aparita ma'am hasn't responded, but I think she has also joined us,
Okay,
and
cool.
all other
So,
speakers have also joined. Yes.
yes, okay, cool. So I will go down the list with just introductions, and I'm sure there's more to know about
Yeah,
all of you here.
Aparita ma'am
And
has
so
also
when you
joined. Yeah.
speak, wonderful. I will go through with brief introductions, but I think when you all speak, you can also tell us a little bit more. I mean, there's obviously things that I would, I might have left out in my introductions. So, yeah, let me just go through the list of people we have here today. It's a mix of politicians, clinicians, and then people who work more broadly in the space of public health. So we have from the BJP, we have Aparajita Sarangi, who is a Lok Sabha MP from Orissa. And she had also served as an IAS officer handling Manrega efforts as the Joint Secretary between 2013 and 2018. And started her IAS career as a district magistrate and collector in various parts of Orissa. So that's Aparajita Sarangi. And we also have from the RJD, we have Manoj Kumar Jha, also a parliamentarian and the national spokesperson for the RJD. Currently also a professor at University of Delhi. And the notes that I have don't mention what you're a professor of, but sir, when you're speaking, you can just also tell us a little bit more about what you're doing. And from the YSR Congress, we have Krishna Lavu. He is currently also a Lok Sabha MP and the vice chairman at Vignan University. And he studied media studies, excellent, just like me, from La Trobe University, Australia, and the University of California. So I'm excited to hear what Mr. Krishna Devarayalu has to say. From the medical space, we have Dr. T.S. Clare, who is currently the chairman at Fortis Hospital. And I know Dr. Clare from various stories that I've called him up on. He is a cardiologist and has been working as a cardiologist for 37 years and did his MBBS in Patiala and then his further studies in Chandigarh. And we also have Dr. Bhaswati Bhattacharya, who is also a physician in practice, trained in family medicine and preventive medicine. And since 2013, she has been a clinical assistant professor at the Department of Medicine at the Weill Cornell Medical College. And has also, I believe, completed, it says PhDs in plural. So if that's correct, that's amazing. PhDs in pharmacology, neuroscience, and Ayurveda, also a master's in public health, Fulbright specialist in global public health. That's a lot of academic and clinical experience there. And we have Mr. Samir Wagle. Is he also here? I am just looking to see if he's currently on. I think he's on. I don't see. Yes, I see the video. Hi, that's Mr. Samir Wagle. 26 years of experience in the venture capital space, and his areas of work have been India, Southeast Asia, and North Asia. Currently, the managing director at the Asian Healthcare Fund, which is a private equity firm focused on investing in healthcare and related areas. And we also have Ananya Avasti, who is the assistant director at the Harvard School of Public Health, the India Research Center, which is in Bombay. And she has a master's degree in public health from Harvard and serves on the advisory board of the Harvard Business School as Business Schools India Research Center. So I think that's a good mix of people from across the board, and the format is fairly simple. It's I would invite all of you. I will just go in the order that I introduced you all, and if you all can, I will keep time. So let's try and be as tight as possible, because we have to get through a lot of people, and there will be questions at the end. So if you all can, when you speak, tell us a couple of things. I may not have introduced you fully, so maybe complete the introduction. Tell us if there's anything else relevant that we should know today for this topic of discussion in terms of your work in the past in the field of healthcare, and also things that you may be wanting to do going forward in this field. And so those are the two things you can discuss. And the third thing, to speak to this topic of discussion, which is on the right to healthcare. Now, one can speak about this in legal terms, one can speak about it in sociological terms, in political terms, or in public health terms. So I would leave it to you to pick whichever manner in which you want to address this question of the right to health. It's not, of course, purely a legal issue. When we talk about rights, we tend to think of them legally, but it's not a purely legal issue. So if you can bring in as much thinking and perspective as possible on this idea of the right to health. Do we need a right to health? Would it serve anything? I mean, we have parliamentarians here. I don't think there's a lawyer specifically here, but does it serve anything at all if we have a right to health, or is it a kind of a moot point? Perhaps right to health is already protected again under the right to life, which we do have in India. Would it improve anything if we had the right to health? Or is it just a matter of, we have enough laws in this country, which is very often the case, and we just need to kind of implement them through courts and bureaucracy? And I think there's expertise here to speak to that. We do have a former bureaucrat here as well. So talk about the right to health, and also talk about what it might mean. And I would really encourage people to speak as practically, and not just in theory, but really as practically as possible in terms of what it's going to take to make healthcare accessible, affordable, and available. So if we can begin with Ms.
Yeah,
Sarangi.
I got it back.
Yeah, if we can begin with Ms. Sarangi, and I would encourage if everybody else can keep their audios muted. And yeah, if we can begin with Ms. Sarangi.
I think I would like to hear two of you, and then I can be the third one. I know I have to go after an hour. There is a TV debate. I'm also the national spokesperson of my party. So, but I really wanted to listen to two of you, and then I would have spoken.
Got it. So Ms. Sarangi is very specific about two people before that. So she will go as number 3. So if anybody wants to throw their hat in the ring first, that's fine. Otherwise, I will request Mr. Jha to go next.
Anu, I'll prefer, because my internet seems to be unstable. So I want somebody to begin, and then I'll pitch in, because I suddenly lost the connection. So I'm trying to fix it.
Mr. Jha also doesn't want to go first.
No, that is not the reason. I lost my connection in between. So I'm just making it sure that it continues for some time.
Got it. Okay, so I am now going to put somebody else in the spot and ask Mr. Krishna Lavu to
Anu, can I speak 2 lines before, if anybody else is not speaking?
Yes, sure. Yes. Who is this? Sure. Is this Mr. Claire? I can't make out who's speaking actually.
This is Dr. Claire.
Yes, Dr. Claire. Yes. Okay. Why don't you jump in?
See, the thing is, I'm in the healthcare sector in India for the last 32 years. Okay, now the question of constitutional right to health, right to life. Actually, it is 21 Constitution in the Indian Constitution, 21 number, which says Constitution to the right to life, and it includes life to health as well. In my opinion, any right of any citizen, if it is not being fulfilled by the state should be punished. There should be punishable act, but that doesn't happen in India. So in practice, this Constitution Law 21 is theoretical as far as I'm concerned. Okay, so now I think you can start the things further, but in my opinion, it is just on the paper, because if there is no punishment, then there is no constitutional right. What is my right? The people are not able to get medicine, people are not able to get beds, people are not get vaccination. So what kind of right we are talking about?
Yes, I think you're right, Dr. Claire. There's a lot of there's a lot of litigation in courts of people trying to secure access to healthcare now, and courts are almost functioning as another ministry and a bureaucracy. Okay, so that was some brief comments from Mr. Clare, but I will go to Mr. Lavu if he would like to open the floor from the perspective of the lawmakers.
Yeah, thanks, Anu. Nice to see bright minds coming together. To start off with, right to health, when we think of it and when we are talking about it, yes, it is needed in this country. But when we talk about right to health, my mind goes back to right to education, which was passed almost 12 years back with much fanfare. But when we see the progress that has been made in terms of right to education, what has happened was the law has been enacted, but what governments have done, at least the central government has done, successive central governments have done, was they just pushed the burden straight into the private player's hand rather than actually government stepping forward and doing its bit. If you see this successive governments and the investments in the education in the last 13 years after the education was passed, it was not to be seen making a huge difference. Same way, we may enact laws, we may pass laws. Coming to right to health also, we may pass a law. Very much welcome. But the question that we need to ask, or the issues that we need to discuss, is how we can make it affordable, how we can make it accessible to everyone, how we can take it to every nook and corner of this country. The good quality healthcare is the question that we should be asking. Passing the law is, in this mood wherein when we're seeing this pandemic and everything, everyone's like, okay, let's push the law, and the debate will start, and with the fanfare it might be passed. But are we going to make make any difference? Are we going to make the central governments and state governments actually make healthcare and education the priorities? If we can make them priorities, how much investments that we are going to force the central governments and state governments to actually make into the healthcare? If we force them to make, if we convince them to make these investments, where are they going to get these funds to actually make these make these heavy investments into the healthcare? If they make the investments in the healthcare, we have to talk about where they should make the investment, whether they have to make it compulsory insurance policies, or we make them push to make investments in the rural healthcare. Some these are the questions that we should be discussing, and we should be forcing the central governments and state governments to come with a detailed plan, and make sure everything is good. We have seen in the last 6 to 8 months or 1 year that we in India, we plan a lot of things, we talk a lot of things, but the question is the execution part. The question is allocating the funds for it and making sure to execute it, follow up in such a way that all the plans are executed on time on the ground. So these are the things.
If anybody else would like to go, that's fine. But otherwise, I will move to Mr. Samir Bagle, and Mr. Lavu can finish his points whenever he's back. And then after that, I will move to Ms. Aparajita. So Mr. Bagle, if you're here. Yes, I can hear you. Yeah. Okay.
So I'll just start. Just to reintroduce myself, I work with Asian Healthcare Fund, which is a venture capital fund focused on the healthcare companies. We invest into early growth stage companies, which are focused largely on the mass market in India. And I have also, in my previous life, done a lot of impact investing through my association with Avishkar Micro Venture Fund. So that's a quick, you had requested, so that is a quick snapshot. So just coming to the point, I think the basic issue today is that India as a state does not spend enough on healthcare. As a percentage of GDP, we are at 1.3%. And we have been talking for years that we need to increase the spending. to 2.5, 3%, but till now it has been largely empty talk. So I think right to health and all legislative changes are all fine. But I think more important is to translate that intent to improve healthcare in actual financial resources. So I think most of us or all of us will know that India has fairly poor healthcare infrastructure, in terms of doctors per patients, in terms of beds per population, and especially the primary healthcare system outside the cities is broken. And the pandemic has today only brought out in great contrast the lacunae in the problem in the system. But these problems have always been there for the last 30, 40 years. So I think so I will have two kind of broad suggestions. One is on the public health side, I think very important to increase the resources that we allocate, reprioritize resources. I think for the next 10 years, we need to invest in healthcare. Healthcare, unfortunately, has not been a political issue till now because the impact of spending of healthcare is a longer term impact. And from a political perspective, the dividends don't come in those 5 years. So it's logical that it is not something that most governments have focused on. I think that has to change. A more longer term perspective has to be taken. We have to reprioritize spending. I think I have no political views, but rather than spending on temples or statues or mosques or whatever, we need to spend money on primary healthcare centers, on hospitals, on schools, because if our social infrastructure doesn't improve, we can have a Right to Health Act, Right to Education Act, but those will be only on paper. Third is very important is we need to improve the health talent in our country. And I think we have taken some steps recently by this government on reforming the MCI and all that, but more needs to be done. I think the biggest challenge India faces is lack of doctors, paramedical staff and all that. That has to change. So that is the first part on public health. Second is the role that a private sector can play in this. I think we have to also encourage private sector because it's a very complementary role that the private sector can play along with the public health system in terms of bringing innovations, in terms of bringing innovative products, innovative business models, and working with the government system in making the patient outcomes better. And particularly today, after the pandemic, for example, using technology to make our existing healthcare system a lot more efficient and increasing the efficacy. So I think right to health is legislative change is good, but more important is actual intent and spending. That's the point I wanted to make. Thank you.
Okay, wonderful. Got it. Thank you, Mr. Wagle. And I see Mr. Jha has been flipping through the copy of the Constitution. So maybe he's got something ready to threat us now.
Thank you. Thank you so very much. First of all, I think thank you, Policy Metrics, because last couple of weeks have been very difficult for us individually, collectively. I know everybody in the panel, whosoever is, even participants, they must have lost someone close, a friend, somebody in the immediate or the extended family. So the pain of this pandemic is quite personal to the collective called India. And that's where I locate the very idea of having this discussion. I'm very thankful to Dr. Clare, who said in the beginning, Article 21, right to life. If our constitution is read carefully, which is hardly done, and sensitively, which is rarely done, I think right to life has to be clubbed with freedom of body, mind, as well as entitlements. So together with Article 21, 38, 39, 42, 43, and 47, if you put together, I mean, from 38 to 47, I refer to as directive principles of state policy. But there have been judgments, and one judgment is in front of me, that is Paramanand Katara versus Union of India. And then another Paschim Bengal Khet Mazdoor Samiti case 1996 and Paramanand Katara 1989. Both these pronouncements were very clear that how should we view our health, public health. But unfortunately, the regimes then, the regimes now, as somebody said, I think just before me, there was a medical friend who said it beautifully, that investment in health does not appear to be, so far it did not appear to be giving electoral rewards. So most of the government, most of the people, they kept it at a bare minimum level, and we have seen how public health infrastructure, I'm no say opponent of private players in the health sector, but I believe in a country like India, when I look at my state, Bihar, where good private hospitals are located in 2-3 districts, 2-3 towns, Patna, Muzaffarpur, Bhagalpur, Darbhanga, rest of Bihar and Purnia, rest of Bihar depends on primary health center and a small Sadar Aspatal, what we call district hospital, which has nothing. I'm told by my own district that there are ventilators, but there are no people to run those ventilators. I think this pandemic, and let's keeping aside the blame game, why it didn't happen, why it did happen. The important fact is that this pandemic and the devastation it has caused has given us at least an idea what should be done on immediate priority basis. Because, very interestingly, I'll tell you, many of you know, I'm not saying anything which you do not know. It's just a collective engagement of mind with a heart. I tell you, most of us look at social media, Twitter, Facebook, Instagram for appeal. I'm worried. My village, they're having cases, but most of them are eating paracetamol. People are dying, and it's not a case of only my village or my district. Most of us looked at it as a city problem, and we were worried, and rightly so. Hospitals having no bed, no ICU bed, no oxygen. For the first time in my life, I tell you, you rightly asked me, what do you teach? I teach social work. I'm a professor in Delhi University. So I come somewhere between the patient, nurses, medical healthcare professionals, and a doctor. Somewhere social work has a role in medical, in institutional care also. But I never knew, believe me, that oxygen cylinder, people crying for oxygen cylinder have to run individually. I always thought hospitals have this inbuilt mechanism. For the first time, as Dr. Claire and other also said, even I think Krishna also said, first time we realized that how vulnerable our systems are, how fragile they are. And they are fragile, they are vulnerable only because we never looked at the fact that right to life doesn't mean anything. It is simply a meaning. I mean, I always believe words should have meaning as well as feeling. This entire set of words, right to life, is meaningless if it is not backed by supportive mechanism. And I believe when you say accessibility, availability, affordability, so the onus also should come back on us, the lawmakers. And I have no qualms in saying that if you examine before the pandemic, I was just doing some rough exercises. Out of 100 questions, if you ask me about the question hour in Parliament, before this pandemic, out of 100 questions, only 2 or 3 were around health issues. And least of them were around public health infrastructure. So that tells you this pandemic at least has given us a chance, cutting across political line. Individually, some of us have been working. I tell you, for the first time in my life, I've lost friends. I've taught students. They were in the age group of 35, 40. and they were doing well in life, but could not manage a hospital bed. They died. So each death at a personal level is a reminder to us that, leave aside political barricading, political lines, even if it is sounds theoretical today, as Dr. Claire said, I wish to many ideas were once theoretical, but they have now moved on their path, trajectory of pragmatism, doables. I can only wish I could have added much more thing, but I would only say that priorities should be public health infrastructure, as somebody said beautifully. Our entire national discourse has been so misplaced in last so many years, so misplaced. Big buildings, big temples, big mosques. मुझे नहीं लगता है कि दुनिया में कोई भी देश ह्यूमन डेवलपमेंट इंडेक्स पे या इस पर या उसका नाम सिर्फ इसलिए है कि उसके पास बड़ी चौड़ी मस्जिद है, लंबे गुरुद्वारे हैं और भव्य मंदिर है. When I see bodies floating in river, I see our collective failure. We must own it up. Acknowledgement is the first step for course correction, and we need it badly. We owe to the people whom we have lost. We owe it to people who trust in us. We owe it to the Constitution of India. That's it. I can't say much more than that, Anuji. Thank you so much.
Yes. Thank you, Mr. Jha. And I think we will get back into a lot of the themes that you've raised, but also others have. This question of public versus private is very important. And as a reporter, I've written so many stories about this, especially when Ayushman Bharat came up. And I'm still trying to figure out, what is the best way forward or the best mix forward for India. So it'll be great to hear more on that. I think Mr. Bagle can speak more to that. And I think, a theme that is on the top of everybody's mind right now and is...
Anu, can I just take 20 seconds?
Yes,
It was Dr. Bagle whose name I was missing. So I must acknowledge the two doctors, Dr. Claire and Dr. Bagle. They put things in much more better perspective than so far.
Mr. Bagle is not a medical doctor yet, as far as I know.
I wanted to clarify, I'm not a medical doctor. I work in the healthcare area, but I'm not a medical doctor.
Anyway,
Mr. Bagle works in the health finance sector, so he should know more about what we're going to do about money and where we're going to get the money from. Our two doctors are Dr. Claire, medical doctors are Dr. Claire and Dr. Bhattacharya. Yes. So I will just move now to Ms. Sarangi, and this is the question that's on everybody's mind, and it'll be good to have some understanding, and I think we are a resource-strapped country, no two ways about it. We have a lot of people to take care of, and we have historically under care. And now we have a government which has got an overwhelming majority for the second term, and I'm very happy to go out there and say there will be a third term for this government. So this government does have, I would say, currently a 7-year period in which, something could have been done about healthcare, another 3 years to go, and maybe another 5 years after that. So there's a 15-year period, So I would imagine that there needs to be some sort of long-term planning also about what this government is going to do. So Ms. Sarangi, can you tell us how we are going to reconcile these contradictory ideas of, you know what my question is, Central Vista, temples, all of that versus bodies floating. I mean, this is not even exaggeration now, it's actually true, right? So how do we do it? I mean, on the one hand, can we always say we are a poor country, but somehow we have money for these things? How are we going to make this work? Ms. Sarangi, you're in the hot seat.
A very good afternoon to all of you. At the outset, I thank all the organizers for conceptualizing the entire idea of this kind of gathering. I also thank them for another reason. I thank them for getting the right people on board. It's a good mix. Today we are talking when 3,26,000 cases of corona have emerged in the last 24 hours, and around 3,970 people have died. This is the right situation to talk about health. But at the same time, I would say health is one element, one item that should be talked about for 365 days a year, not only during Corona. But yes, of course, when we are battling with this, I would say this is definitely the right time to look at the gaps and to decide on the ways and means of filling in those gaps, to plug the holes. Now, my dear friends, all of you have talked about Article 21 of the Constitution of India. We also are well aware of the directive principles of state policy, Article 38, Article 39E, Article 41, Article 47. I would not like to get into those. All of us are well aware. Now here, I am not talking to you as a spokesperson of the Bharatiya Janata Party or the central government. I'm speaking to you as a citizen of the country. Let's compare our country with all the Southeast Asian economies. Don't talk about US or UK or any other Western nation. If Indonesia is far ahead of us, if Malaysia and Singapore are far ahead of us, it's because of only one thing, the thrust of the government on human resource development. Everything boils down to human resource development. Everything. Our country moves forward, our country goes backward, depending on the kind of focus that it has on human resource development. Now, what does it mean? Human resource development means thrust on education and health. Education is extremely important. Quality education. When I say education, it is not just universal education, it's quality education. And when I talk of health, I mean quality health, affordable, access available, the topic of today's debate. My dear friends, what's the scenario here? As far as our country is concerned, let's not look at others. Let's not look at others. It's very easy for we Indians to just talk about others and say, okay, we are better and they are less than us. It's not so. Let's look at ourselves, forget the other parts of the world at this juncture. What's the scenario in our country? While the UK has one bed for about 385 people, and USA has one bed for 416 people, we in India have one bed for 1,881 people. Now, as far as the doctors are concerned, I think that is also quite disconcerting, very disturbing, so to say. US has one doctor for about 345 people, UK for 357 people, and we for every 746 people. And of course, we need nurses. Now, for nurses also, UK is one nurse for 113 people. US is one nurse for only 85 people, while we are one nurse for 588 people. My dear friends, the other issue regarding the situation in our country, the health scenario. We are spending not 1.3, 1.11% of the GDP on public health. Now, let me honestly tell you that I belong to a party which focuses a lot on health, and Prime Minister Modi has already decided, and the team is going ahead with the entire mission of converting this 1.1% to 2.5% of the GDP by 2025. We are working towards it. Right? What happened? Why did we fail in Corona? Now here, there is always demand and supply mismatch. Think of a situation where you have invited about 10 people to your residence for dinner. You are getting ready for 10 people, right? You may feed maybe, 15 numbers of people, not beyond that. And suddenly you see 100 people land up. What do you do? So it's the same thing which happened here. So I think, my dear friends, we really need to look at the whole corona management from that angle. It's a demand and supply mismatch. And it is once in a century pandemic. Let's accept that. It's once in a century pandemic. It's not endemic. It's pandemic once in a century. And it's the second wave which has hit all the nations. It has hit our nation. And let me tell you, all of us, cutting across party lines. Let's not get into politics when we talk of two things. One is development and the other is corona. Keep aside the parties. The state governments, the central government, the voluntary organizations, all of us are working in tandem. And we cannot say that even one person is not putting in his best at this juncture. Each one of us, we are trying to put in our best. And you know what is the Suraksha Kavach? Suraksha Kavach is vaccination. Now, leave aside corona. What do we need to do now? Let me tell you that we need to focus on our infrastructure. Very important to focus on the infrastructure. Now, when the National Rural Health Mission came, when the National Health Mission came, I was in the district as district collector. Everywhere. I have never worked in the health sector, unfortunately. I was secretary of my state in the rural development department, and I was handling Manrega with 60,000 crore budget for 5 years here in Government of India. But I never worked in health. But whatever I have felt, whatever I have seen in the field, important to focus on infrastructure. Now, when I talk of infrastructure, I just don't mean buildings. Buildings, yes, very important. We need to have PHC building. We need to have CHC building. We need to have a good district headquarter hospital. We need to have a blood bank. We need to have an emergency section. Fine. With quality manpower, we need to have these buildings. With good equipments, we need to have this building. So all these things have to be brought together. Quality manpower, trained manpower. We need to have the proper equipments, and we need to have good buildings. That's how it is. And let me tell you honestly, over a period of time, I was district collector in 2000 in the district of Koraput, one of the KBK districts. Things have improved. We can't say things have not improved. We'll not get into which particular party was running the government at the center or the state. Let's not get into that. But yes, there has been upward trend everywhere, and things have come. You know, we have really moved forward. I must say that. However, the quality health is missing. So I think we need
yeah, I just want to come in right now because I think you have to leave also, right? What time are you leaving?
What time do you want me to leave?
Not at all. I would prefer if you stayed. I would prefer if you stayed, but just want to know because
I cannot hear you. Sorry?
I might have questions for you. So before you might leave,
I would be leaving. I have to defend the education policy in News 24 at 6 o'clock. So I will be taking another maybe, 15, 20 minutes. I'm there. So how much time do you want me to be here? You tell me. 6:15, I can leave.
Okay, I'm so sorry. I'm having some problems with my audio. I didn't hear everything. Abhishek, can you just tell me what Ms. Sarangi said?
6:15. Can I leave at 6:15? Is that okay? 6:15. Can you hear me? I'm not able to hear you now. But 6:15, till 6:15, I'm there.
Problems on my end. The audio has been a bit of a problem. So I didn't hear everything that you said. But what I'm saying is we should take some questions before you leave. So I will keep time.
Done.
Got it.
Done.
Yes. Okay. Thank you. So do you just want to wind up what you were saying or should I move?
You want me to, whatever you say, you're the boss.
Okay, let's
I
just
can
move.
stop anytime. I can continue. I'm absolutely flexible.
Okay, good. Let's just move because there are another 3 people who have to speak. And I apologize, some technical issues on my end. And then I will ensure to come back to you before you leave.
6:15, I will have to go. So that's how it is.
Okay.
Right?
Thank you. We will move to Dr. Bhattacharya. Yeah, ma'am, if you can just come in with your thoughts right now.
Okay. So when I thought about the right to health and making healthcare accessible, available, and affordable, you introduced me. I have quite a lot of academic background from some of the top places, both in India and in the USA, I found that in my mind, three main circles kept coming up as I was thinking of the issues, both practical and the way forward. The first one, several people have touched on, and that is about education, human resource development. So there are about 1 million, it's like 1.2 million allopathic doctors in India. And having spent the last 8 years here almost continuously as a Fulbright scholar in public health, and then doing my PhD in Ayurveda at Banaras Hindu University, and meeting up with a lot of people around the country, I got to know more about the Indian MBBS medical system. As an MD myself, but from the US side, having spent most of my career working in hospitals, mostly in New York Presbyterian Hospital in New York, I always thought that the doctors in India are really well trained because they get to see so many patients. In the USA, there are great programs that are theory, but when it comes to seeing patients, many of them are not allowed to touch patients, so they don't get the same level of clinical experience. But then I came to BHU, which is a central university, and I traveled around India. And one of the things I realized is that, and I know because I have talked with so many thousands of doctors, many of the doctors who do not get the education at public, really good medical colleges, which there are in India, the rest of them go to these private places where they pay 2 crores under the table to the dean or the professor or whoever. Their daddy, because most of them are 18, 20 years old, their daddy pays that 2 crore because most guys don't have that kind of money at that age. And they get a credential 5 years later, 6 years later, which is an MBBS. I'm not saying this is all doctors, but I have been shocked to see how many MBBS doctors actually have that. Because as a person who practiced in the US for so many years coming here, I just assumed that it was because of what the others were saying, what Aparajita and Dr. Claire and Mr. Wegley had said so far. I thought it was just that we don't have enough doctors. But when I see the ability of those doctors, when I interacted during my PhD in the library with those MBBS doctors, I realized that they just want their credentials. And when they go out into practice, they want to make money. And most of my doctor friends in Delhi, some of the famous doctors in Delhi and Bombay who I meet at the best parties of the Ambanis and the Dukes, they are actually more interested in making money, and they don't really want to help the patients at any cost. First, you deposit your 5 lakh rupees, then you'll get a bed in my hospital. So that kind of an attitude is a little bit dangerous, I think, for India. And I think that's something that we don't address head on because, well, we'll talk about why we don't address it. There is a lot of money that needs to be invested toward good quality education, as Parajita beautifully said. HRD is the key for India's wealth. When we talk about the people who are poor, some of them are poor because they don't have skills that have been developed. Many of the doctors are afraid to talk about how incompetent they are because of the prestige issue and all of the peer pressure. I have been talking on WhatsApp groups as well as my friends all around India, MBBS friends on one side. I'll talk about them first. And they say, you know, we just don't know what to do. I go to work and we have people that are not that well trained. We have MBBS doctors that have just gotten their license prematurely because we need more doctors. They turn up the O2 cylinder all the way, not realizing that that is not how to get oxygen. If you want to deliver 90% oxygen, you have to turn down the cylinder. They don't know how to use the equipment. In the US, my friends were saying, you know, we have ventilators that they brought in, but the doctors don't know how to use ventilators. They don't know how to actually how to set up all the different controls. You have to be a really well-trained pulmonary technologist, respiratory therapist. So the idea of specific examples of where doctors, just because they're MBBS, doesn't mean that they're actually competent comes up. When I was looking at the News 24 and all of the cars lined up around the hospital and how people are desperate for oxygen and they're dying in the back of their cars, I was thinking, you know, there's a book called Where There Is No Doctor, which is used by those of us who have done international medical missions all around. I was one of the ambassadors for the Orissa supercyclone in 1999 and saw the devastation in Orissa. And we looked at that book for public health, and there were not medical tertiary care facilities. You can take steam inhalation and do really well when you can't get oxygen to help yourself. And in fact, when I got sick, I was doing steam inhalation because it really helps bring my oxygen was pulse oximeter said 77%. Okay, I can't breathe. I go and do steam inhalation. These kind of things need to be taught. So there is a model. It's the best that I've seen. It's at Hofstra University in New York, and they actually have a model where they train the doctors to become emergency medical technicians in the first semester, so that those medical students, while they're still curious, while they're still studying the books, are getting actual clinical experience. And I would love to roll that out in India so that the doctors who enroll actually show their ability to be clinicians in the first semester. This kind of a program and programs like it that use case-based studies, mentoring from the first semester, allow people to have more devotion and also more willingness to be actual clinicians that are competent. You know, they'll think about it. So just want to put those out there. We can talk more about core competencies and how to train doctors. I've thought about it a lot. I've written a lot of letters to people in the healthcare system at state and national levels. For some reason, I don't know, I guess I'm not nepotistic enough. I don't know how to get into the doors of the doctors at Niti Aayog or ICMR or MCI, where they're actually making decisions and contribute some of this knowledge. But what I've seen through my native Kolkata, Delhi, Bombay, Udupi, where I've spent a year, and Banaras, where I am now, is that academia is really rotted. The kids come in who are 17, 18 years old. They are bright and they are able. And over the next 5 years, due to harassment and corruption and teachers taking their, just disrespecting them, they have become jaded and they don't want to help patients. They just want to get out of medical school and practice and make a lot of money. So that's the first issue, is the entire reform that needs to happen that people are not talking about, in addition to all the good points that people have made about the mainstream system. Second is the issue of health freedom. Health freedom, you know, India is actually on this planet, it's the model country for health freedom. We have 8 legal medical systems here. And with those 8, which include the Ayush systems, as well as mainstream allopathic medicine, patients have the right to choose. And those patients that choose Ayush systems are not counted. So when someone says we need more beds in hospitals, you know, if you go back 200 years ago, people were treated in their homes. And many, many cases that go into the hospital can be treated in their homes. I, in fact, had COVID for 19 days, COVID pneumonia, and I was treated in my home. And I felt safer in my home because I can make my own food. I don't have dirty bed sheets. I don't have some lazy or stupid or dumb paramedical person. I don't have a doctor traveling from one room, forgetting to wash his hands and coming with his same clothes and touching me. And I've seen doctors do it, so no one needs to argue with me about that. And I know the hygiene level of doctors because I've seen their homes. Most doctors and healthcare professionals are not clean at home, so they're not going to be clean in the hospital. So we have major hygiene things we need to do in the healthcare industry for anyone that actually practices medicine. Because we have those 8 legal medical systems and we have 600,000 Ayush professionals who actually were begging to be allowed to practice in the cities and the rural areas and the suburban areas and were not given permission. In fact, I wrote a column in the Times of India in March, and a couple of days later, Modi actually had a meeting with several Ayush practitioners to say, what can you do? Ayush practitioners don't get the same kinds of educational resources. They are not as articulate, and they come from a paradigm of thinking that is frankly laughed at by MBBS doctors. And so anytime they try to say, you know, Guduchi would be a good thing for you to take, you know, your Kada would be a good thing for you to take, steam inhalation would be good, they're laughed at. And yet, the doctors, the few doctors I know that practice both allopathic medicine and one of the Ayush systems, either homeopathy or Ayurveda or Unani, those of us, there's a few of us, we call ourselves integrative doctors. We have found that integration is the key to not only beating COVID, but the politicians that I know, I dated an MP for 2 years, they go under the table quietly, they find the homeopathy, they find the Ayurvedic remedies, they find the other things, and they don't tell anyone. And they don't bother to stand up for legal access for other people. So the fact that Ayush systems are being used but are not being given the credibility that they need to be, and there's a huge workforce out there that could be trained to higher levels of ability in 6 months because they're already credentialed, they're already licensed, they're already Ayurvedic doctors, homeopathic doctors. It's a very sad thing that the IMA.
Thank
Yes.
you. I just want to interrupt you because I think you've made some really good points, totally fresh points, which other people have not made about the problems plaguing workforce and the ways in which we can perhaps boost the workforce by enlisting additional healthcare professionals from the Ayush space. So those are some really fresh points you've made. I will just ask if I can move to the other people right now so that we can come back to you as well.
Yeah,
we're running right on time.
One more sentence, please.
Yes, please. Yes, please.
My third point, which I can discuss if you'd like later, is about dharma and the fact that we have two conflicts. One is the doctor's dharma, which should be about being well qualified, sincere, and looking toward cures for patients, and the dharma of business, which is about the things that Dr. Waghale and some of the others who are invested in the economics of healthcare are looking at. That's their dharma. This is another dharma, and I think doctors are confused. I'll leave it at that.
Got it. Okay, cool. So let's just move to Dr. Clare right now. Ms. Avasthi is also waiting to speak, so we'll just move to Dr. Clare. Dr. Clare, if you're on, otherwise we will move to Ms. Avasthi immediately.
I'm on.
All right, I can hear you. You're muted right now. You're muted, Dr. Clare.
Okay, I'm audible now.
Yes, go for it.
See, Dr. Bhattacharya has made many important points, but let me tell you that there are roughly 280 private medical colleges and 280 government medical colleges. In government medical colleges, in every state, there is a 50% reservation, correct? And in private medical college, what she said is correct, that you pay 2 crore under the table and get your child admitted. Now, if we have rules and regulations like this in our country, then how can you expect a quality healthcare workers in this country? This our politicians have to understand. I don't understand any reason why there is a reservation in medical field at all. This has to be finished. Nobody speaks because in India, the problem is that there is a vote politics, purely vote politics. Lack of accountability is the central theme of this country. You make rules, you do this, do that, nobody is accountable. There is a disaster. There are people dying with the lack of oxygen, but nobody is answerable.
Dr. Clare, just one thing, I just want to flag off this one thing right now. There are very historical and necessary reasons for reservations in this country.
That should finish now, madam. That should finish now. It is already 70 years of independence, you know.
Dr. Clare, 1 minute. I'll just finish my point. I don't want this discussion to get into a casteist space where we criticize people from scheduled caste and scheduled tribes for the historical oppressions that they faced and the difficulties they still face in accessing education. So let us not go into that space. That would not be correct. But if you can just move on with some of the other points that you're making. Yes.
Yeah, so the thing is, you know, again, the question is, there is a public health, there is a private sector. Private sector takes care of 70% of healthcare in India now. So you cannot ignore the private sector. Private sector has to be involved in every possible thing. Now, you know, when we talk about government public sector, you go to civil hospital, they are in shambles. Okay, there is in private hospital, they said the NABH accreditation is a must. Then tell me why the government hospital should not have a must accreditation of NABH. They have to have a minimum standard, but no, they are not answerable to anybody. So in district civil hospitals, there are no facilities. they are dirty. So who has to be responsible? Healthcare funding, of course, somebody pointed out, our healthcare, the GDP, we spend only 2.5%. All the European countries average is around 8 to 9%. America spends 16%. So in India, there is a great need to increase the GDP percentage to health, public health care, number one. Number two, more importantly, whatever is available is not being used. Ventilators are lying there, they are getting rusted. The people don't know how to use that. So ultimately, it's not a question to provide ventilator. It should be functional. They should be functional. They should be, people who know how to do things. But problem is, this is all theoretical. Everybody knows, but who is going to bring the people work and who is going to make them accountable? That's all my saying is.
Got it. Got it. Thank you, Dr. Clare. Thank you very much for those points. We will come back to a lot of that stuff. We still have to discuss on the role of private and public hospitals. So
no, I will not be, just a point, I will not be available from 6 p.m. to 6:45 because I have some other channel to go. I'll come back at 6:45 again to answer the question.
Got it. Thank you, Dr. Clare. I think quite a bunch of people might be jumping out of this. Ms. Awasthi, my apologies to you, but I think Mr. Labu has to leave and Mr. Sarangi, Ms. Sarangi is also saying that she'll have to leave. So if I can just go to Mr. Labu before I come to you, Ms. Awasthi, if you can tell us, you've heard some of the the conversations that we've had now. If you can just tell us, on this prickly issue of how we're going to sort out this public versus private debate, and in terms of needing to spend more money on healthcare, but there not being enough money. Now, we every time. When I put this question to Ms. Sarangi, I imagine she will say health is a state subject. When I put it to people in states, they will say we don't have enough money from the center. So what is a good way for us to really break out of this deadlock?
The good way to break out is to actually look at what Andhra Pradesh is doing right now, and what Andhra Pradesh has done for the last 16 to 18 years. We in India get tempted, by passing these laws like right to education, these things, to push the buck onto the private sector rather than government pulling up their socks and doing their bit. But we in Andhra Pradesh have been at forefront at doing some of the things. We're not doing everything right, but in the past 60 years, but we're doing some things right, which are being emulated across the country. Say, for example, 108. 108 was started in Andhra Pradesh. Ambulance service, which when some untoward incident happens, will come in a stipulated amount of time of 20 minutes. It's a call from anywhere. It was started in 2005 or 2006. It was a private enterprise which was started, but government at the time, late Vice Rajshekar Reddy, saw the opportunity and what it was solving, and just lapped it up and made it across the state. And it was such a success that if you see across the country right now, it is being operated across the country. The same service, in the same way it is being done across the country. And the second one that we started, and it was very successful, was Aarogyasri. Aarogyasri was the concept that was started by late Vice Rajshekar Reddy in 2006. Wherein we thought not a problem with accessing the healthcare. Am I audible or am I cut?
Yeah, I can hear you. Please go ahead. Yeah.
Yeah. So poor people should not have problem accessing good healthcare. So he came up with Aarogyasri, and he started the scheme wherein a private he roped in the private hospitals as well into the scheme and made them part of providing the quality healthcare to citizens of Andhra Pradesh at that time. It is very successful. It is being implemented right now in Telangana, and it is being. I believe it has been taken up even by West Bengal in the last year or so. So these are the things, the good practices that we have done, and that in the last 1.5 years or 2 years after Jagan Mohan Reddy came into power, what we are trying to do is to strengthen the PHC centers, primary healthcare centers. We are trying to recruit as many doctors into primary healthcare centers, and we are also in the starting medical college for each parliament across the state. So 25 colleges are coming up in private, which is started by the government. Government itself is starting these private medical colleges. So by doing that, we want to create enough number of MBBS doctors in the market so that affordable health can be given in the nook and corner of the state. These are the things that we are working on right now, and which can be emulated across the country. But going forward, we need more resources, more funds to be allocated in developing the area hospitals, in making sure that the doctors are actually present in the primary healthcare centers, to strengthen them up. And also, we need to give enough confidence to the private sector as well. We're passing laws left, right, and I believe we passed one of the law one year back, wherein if someone injures a healthcare worker in a hospital, he or she can be jailed for so many years or something, or something. But we should ask the question: why there is a why there is a situation where if someone is ready to injure a doctor who served him? Why is it happening? We should be asking that question. Which we are not asking those questions, rather than just passing the laws based on the feedback or based on discussion that are coming in.
Yeah, Mr. Labu, I just asked you one.
Yeah, go ahead.
Okay, so many tech problems. I'll ask you one more specific question. As you know, southern states are much more well off than states in the north where I live. But when it comes to Andhra Pradesh, do you feel like you have enough of the state funds necessary to carry out your healthcare programs? The pandemic has broken everybody's back in certain special ways as well. The burden of funding this vaccination is on the state. So in this specific health situation that we're at, are you as a state going to be able to make healthcare affordable and accessible in this pandemic situation?
We are trying to make it affordable and accessible for more people. We're struggling because we're putting everything on the private players to actually come forward and do the whole work. The public sector is not able to cope up because over the years we have not developed the public sector area hospitals or the government general hospital. We have not developed and added enough bed strength. Even when enough bed strength, we haven't added doctors, enough doctors there. So we feel we're doing enough, but we can do much more than what is happening right now. We can only do that by actually doing much more work in the public sector, adding more beds, adding more infrastructure, adding more doctors to it, and making sure that people, by adding all these things, we can make it more affordable and accessible for people.
Okay, got it. Mr. Labu, thank you for that. In case you're going to and thank you for your time. And I will just quickly move to Ms. Sarangi. If she can take some of those important points that have been raised on and off by different people with regards to just specifically about this pandemic situation and how badly off we are on healthcare, and what ma'am would like to say regarding the 7 years that we've had with this government and the 3 years that we still have, and in terms of this big issue that's on everybody's mind with regards to how funds are being allocated, whether we should be spending funds on cosmetic things rather than healthcare things right now. Abhishek, can you just check if...
Yeah, just give me a moment. I'm checking.
On the call, yeah.
She's not on the participants list right now.
Okay.
Okay, I think we can. I don't think she's there.
She's not available?
I think she has left.
Okay, I think...
Yeah.
Okay, cool. Then let's just move quickly to Miss Avasthi. So sorry that you
Jake, I think Ms. Sarangi has left.
A very good
Okay,
evening
cool.
to all.
Yes,
So
I
I'll
think
be
she's
speaking from the public health perspective. I think from a political perspective, from a legal perspective, we've all discussed that yes, we need to invest in healthcare. Healthcare is in tatters and look at the pandemic. But when we really talk about how systems work, how policies or even electorate really translates into programs, towards the end of the pipeline, we need to look at some of the data. We need to understand where do we start. So I'll try to summarize my points under 4 headings. And just before that, I would like to bring a fact to everybody's knowledge. If you look at the tuberculosis 2020 report, you'll be surprised to find that 23 lakh people in India in a year alone got tuberculosis, and nearly 80,000 of them died. Now, what has happened with COVID-19 is, if I can say, the middle class of the socio-economic quintile, or say the upper class of the socio-economic quintile, for the first time experienced what it is to lose a very, a close someone to COVID. Many of us are now getting COVID in sitting in Delhi and Bombay, and hence we suddenly are rising up to the occasion of, talking about public health. But the fact is, just open up the public health statistics in India, just start with tuberculosis, and you'll realize how many thousands and lakhs of life we lose each year to different kinds of infectious and non-communicable diseases, which are probably reported in newspapers, but it doesn't get into the collective consciousness. So I think COVID-19 has really given us an opportunity to really get public health into the collective consciousness of people, which is really an opportunity that I see in this pandemic. Coming to the 4 themes that I would like to take up. The first is, of course, how much are we investing in public health? As has been rightly pointed out, less than 1.3% of our GDP is invested by the government in public health care. And we don't even have to compare ourselves to US or UK or the OECD countries. Just look at the BRICS countries. You'll be surprised to know that even Brazil and South Africa spend at least 8% of their GDP on healthcare. So this is what we are talking about. Coming to commitments, of course, Planning Commission and Niti Aayog papers year after year have always mentioned that we should increase our expenditure to 2.5%. But I would say we can't wait till 2025 to make that 1.3 to 2.5. Probably by 2025, we should be looking at universal healthcare and pandemic. And there was never a better time to be talking about increasing our public investment. To give you another figure, studies have estimated that in India, each year, 6 crore people are pushed below the poverty line due to the catastrophic health expenditures they incur. So we're not even factoring in the impact that COVID has had, the impact that the lockdowns have had on the lives and livelihood of people. These are the default number of people who become poor each year because of the health expenses that they incur. And why is that the case? This low investment of the percentage of GDP translates into as high as 65% of out-of-pocket expenses. So for example, an average Indian spends 100 rupees on a healthcare bill, nearly 65 rupees are coming out of his or her own pocket, and not by government insurance schemes or not by public facilities. And despite all the health insurance programs, the NSSO, the government data says that 80% of Indians do not have substantive cover for any health expenditure support. And I'll give an example of Rashtriya Swasthya Bima Yojana. It did start off very well, but an assessment showed that even when we roped in private hospitals to compensate for, which were later compensated by the government while people were seeking care, usually these were all tertiary treatments. There was no focus on primary care. And so goes the case even with Ayushman Bharat, that there's a big need. While health insurance is a good thing and a good way towards universal health care, but we tend to miss primary health care in terms of our prioritization. Second theme, what is the state of health infrastructure in India? We are all talking about lack of oxygen ventilators, lack of ICU beds. We've all received those SOS signals on WhatsApp and Twitter, and we're not even talking about the rural population, which does not have access to Twitter and WhatsApp so that they can do an SOS. Before the pandemic struck, I mean, when I read this statistic, when I started investigating it, I was shocked to find that for a 130 crore population, we only had 1,100,000 ICU beds operational and less than 50,000 ventilators. Obviously, when a pandemic strikes of such a big magnitude, and when you have 40 or 48,000 ventilators to, take care of the patient load, you can just imagine that these results that we've seen in April and May are not very surprising given where we are on our health infrastructure. Coming to doctors, of course, many of us may know that or may not know that one government doctor at this point is tending to nearly 11,000 people in the country. So these are the disparities in terms of health infrastructure and bed capacity or health workforce. When we talk about, okay, we get a right to bill, we increase the investment in public health, but then where does your buck go? Where do you really invest this money? A third point that I would like to bring out, especially in the context of COVID-19, how are public health decisions made? I'll give just one example. There's been a lot of reporting, and I'll give both sides of the story. There's been a lot of reporting about how the government was totally caught unaware, with the second pandemic and people, politicians were holding election rallies and everything. But my question is, let us not make that debate very political about temples or mosques or who was holding election rallies. The question is, how does public health expertise feed into these policy decisions when they are taken? For example, INSACOG, which is within the Ministry of Health and Family Welfare, wrote on 10th or 11th of March, warning the government of the new mutants of COVID-19 that have the potential to swarm the country with the second wave. And they wrote to the National Center for Disease Control, which should have taken it up with the Ministry of Health and Family Welfare. And yet, why was the government caught unaware? Another example is the whole question of imposing or not imposing a lockdown. Last year, we were sitting on months, on end with a lockdown. And this year, literally trade associations have pleaded the government to impose timely lockdowns and save lives. It's another debate. How do we balance lives versus livelihoods, which is also an important aspect given what happened to the migrant workers last year. But then how does this policy making happen? How political are these questions? And if they are political, what can we do to drive public health expertise into making these decisions? Finally, I would like to close in terms of, okay, how do we bring public health agenda to the top of, public policy? And I would like to really congratulate Abhishek when he first reached out saying we want to talk about right to healthcare. I had never read about this bill, but I think this is such a critical juncture where we should be talking about increasing the public health investment to at least 2.5% of the GDP. And I would like to put it on record that per capita expenditure for healthcare in India has literally doubled in the last 6 to 7 years, but we have a long way to go. MBBS seats have increased by more than 48%, but like one of our speakers said, what happens to the Ayush workforce? How many of our doctors are willing? Am I willing? I'm a dental surgeon by training. Am I really willing to go to Balia and Basti and man a dental clinic over there and man a primary health care center over there? So we should be looking at Ayush doctors who may be mocked upon, but might be a very, very good resource to upskill, to give them the respect to their health work. Third, we really, really need, it's time, and Abhishek, through your efforts, I'll be happy to contribute. There needs to be, Anu, a common minimum agenda that all political parties have for a public health manifesto, that all political parties by now, really abide by, given the pain, given the experience that people have had in COVID-19. Ideas could be to have a Department of Public within the Ministry of Family. What would a Department of Public Health do? There is so much of a scope for behavior change communication. Large part about COVID-19 prevention is hand washing, is masking up, is vaccination. So there definitely needs to be a dedicated department or a dedicated committee who drives these decisions, who have the right data to understand, okay, once we have the money, where do we invest it? And I would like to again say, put together one other point. I was back at Deloitte, I used to analyze some of the public expenditure in Ministry of Health and Family Welfare and Women and Child Development. And I was shocked to find that not even 60% of the annual budgets are even used by most of the public health programs. So are we talking about financial health management scheme, if we would look at an announcement on All India Medical Services, do we at all the times need an IS officer or an IPS officer to be taking decisions on behalf of public health? So here are my points, and then I'm happy to answer any other questions that may come up.
Okay, wonderful. Ananya, thank you so much. I think Mr. Jha is still on the call, right? Because we're nearly out of time. Some questions that I'd be happy to put them to Mr. Jha if he's still on the line. And also bring in Mr. Wagle, because I think these are questions that are speaking to both of them. Mr. Jha, are you on the line?
I'm there.
Okay, wonderful. Thank you. Glad. So I just, how can we, these are some of the questions that have come in. Now, private hospitals are providing world-class medical care. Why can't we have the same from the government? And secondly, now on the flip side, so this question was one that praised the private sector and wanted to know why we don't have the same quality in the public sector. But on the flip side, somebody else is asking, how can we change the mentality of private hospitals from making them a money-making center to a service provider? So why are we stuck in this binary that private hospitals will provide good care, but they will be money-making? Why can't government hospitals provide us good care? I mean, this is a stereotype. There are a lot of people who will say that this is not true, that public hospitals actually do provide a high standard of care. I mean, they may not be an AC room, but it's good quality medical care by well-trained professionals. Many aspects to this, but both of you, why don't you have a go at it?
Anu, thank you so much. I'll not take much of the time. I'll just pitch in because Ananya, in fact, has in part by raising or flagging these issues, she has answered. I would remain in sync with what she has said. Something, we must look at the size of our country, the diversity of our country, and particularly the hinterland. Today, Corona appears much more worrisome because it has reached the hinterland, and I'm telling you, watch out reports from Bihar and UP that will tell you that most of the villages are affected. I can cite any number of cases. You know why? Because the nearest health facility is actually in a district which is hundreds of kilometers away. There itself, as I said, there is a Sadar Hospital which cannot cope with this ravaging kind of pandemic. So, having said that, it's not if I go into the theoretical engagement of it, how it happened that the private health infrastructure has built on in this way, and public health infrastructure it has eroded in past couple of years. So that would take me to the entire neoliberal politics and neoliberal economies. With some other time we'll discuss that. But as of now, what is most important, one suggestion, that if organizations like you, advocacy instruments, if you prepare and put it in the public domain, because everybody has experience the personal pain, as I said in the opening remark, that nobody in this panel, nobody in my parliament, any member can say that he or she has not lost somebody close to him or her in the family, in the friends. Now, in this kind of situation, only commitment what is expected out of us, with support from people like you, organizations like this, that we must have a committed health manifesto, a bare minimum kind of thing, that all political parties, you might disagree with each other ideologically or in terms of specific nut bolts of politics, but here we should have a broad consensus. Number one. Number two, I would not have you flag this issue, and rightly so, about this, because the kind of article, directive principles I quoted, 38, 39 to 47, in sync with Article 21, they are not hanging in air. They are part of the social justice paradigm. So let's not think that merit, and we don't have enough meritorious people. So you rightly settled it. Number three, what I believe, and believe very strongly now, whatever we'll be able to do in the coming session of Parliament, we would need support from, say, a platform like this. And I promise, on behalf of my party, on behalf of some of my friends which are different political parties, that we'll have a committed session or committed time frame on making sure that right to health does not, I mean, it shouldn't be again after a year that we sit down and demand about right to health, accessibility, affordability, things like that. Finally, I would say that as I said earlier, private hospitals look good, but please see, where are they located? Look at their location. What kind of nation we are? Where is the maximum need? I cannot imagine. I live in Saharsa in Bihar. If my parents fall sick, they have to travel 250 kilometers to Patna. In this kind of situation where individuals are literally dying to get an oxygen cylinder, oxygen concentrator, things which we didn't know. I'm not from medical fraternity. I never knew there is something called oxygen concentrators. So this pandemic has told us that much more important than anything else is that commit yourself to Article 21. And Article 21 is not an empty word. It has to have a meaning as well as a feeling. And that is only possible with all due respect to all political parties. Forget everything else. Commit yourself for coming 3 years that we are going to do this. It's going to be a reality. I hope if something comes out of it, I commit myself as a small voice in the parliament. Thank you so much.
Thank you, Dr. Jha. Thank you. That's encouraging to hear. I just want Mr. Bhatt to answer this. This is an internal debate about who's going to fund it, and I think the term that you use is that we would need a mix. But in the sense of this mix, there always does tend to be, as Mr. Jha is saying, a conglomeration of this stuff in urban areas. Now, who's going to go into rural areas? As Mr. will say, who really wants to go to Balia? If you, I think, as Dr. Bhattacharya was saying, after you've spent so much money in capitation fees, who wants to go to Balia? So how are we going to figure this situation out?
So I'll just keep my remarks brief. So see, I think one thing we must recognize is that profit is not a bad word. There is a difference between profit and profiteering. Right? So I think if an entrepreneur is taking the risk, we should not begrudge him his right to generate reasonable profit, which at the same time takes care of the patient interest, because that is the only way that entrepreneur or capital is going to go into areas where there is a huge need. And I think it's also not a binary situation. It is not that it is public health system versus private. I think both have an important role to play in the overall system. The private sector brings nimbleness, the energy, dynamism. The public sector brings purpose, the ability of longer timelines. So we have to marry the two. I will give you just one example. Mr. Lau unfortunately left the call, but in the state of Andhra Pradesh, there are these centers run by the government where they are run on a PPP basis, private-public sector partnership basis, where one of our portfolio companies that we have invested in called Forus Health, which is into ophthalmic screening devices, they have partnered along with Apollo and with the government of Andhra Pradesh to screen patients for their eye problems. And it's a model where the investment is done by the private sector. The patients come from the public sector, and we get paid a certain amount per screening, which is given the volumes is a relatively small amount. And in a period of almost a year, we have screened something like 1.5 million people. I mean, and I'm told that the Andhra Pradesh government under Mr. Naidu, the earlier government, which has been continued by the states, by the current government, has similar models for dialysis, for cancer care, and so on. So I think those kind of models are possible. They have worked, and they can be replicated in other parts. And the last point I want to make is ultimately any system works on few parameters. What are the incentives? What are the regulations? How is accountability created? I think whether it is the private sector or public sector, we have to take care of those things, and then patient interest is taken care of. Thank you.
I would like to ask you a follow-up on that, but maybe we'll come back to that so that I can get into another question. And the thought I have in mind is, in the sense, you were saying there's a difference between profit and profiteering. How much profit, forget profiteering, how much even profit is the private sector entity going to make out of going into a rural area? I think the point you made is that a private entrepreneur will take all of the risk and there should be some reward for that. But I would imagine there's actually, forget profiteering, there's not even a lot of profit to make perhaps by going into rural areas. So, I mean, if we can come back to that, I'd love to hear you on that again. But let me just ask something that if Dr. Clare is back on this call, then probably Dr. Clare and Dr. Bhattacharya can, respond to this. Is Dr. Clare here? I feel like I can see him in the participant list, but I don't know if he's actually close to his phone or laptop. Maybe he isn't, but I will ask my question anyway. And I think if he's not here, then Ms. Awasthi and Dr. Bhattacharya, if you can, Dr. Awasthi and Dr. Bhattacharya, if you can speak to this. What a couple of people have also asked, what is this idea of getting professionals involved in medical care? And there's a lot of fear that it may not be safe, that they may not be adequately trained to handle things. So how do you practically really see this? Is it that, we can have a stipulation of things that Ayush professionals can do and a long list of things perhaps that they should not do, and they should only be seen in a sort of augmenting role to the other systems of medicine, or where we can't really operate in extreme positions. So there has to be some middle path, or it's either some middle path or it's perhaps nothing. So the IMA, for example, will often say that we shouldn't have anything to do with Ayush professionals. What is a way to really get around the situation?
I couldn't hear half of your question because of the audio jumping in and out. But I think you said something about Ayush professionals. Is that right? Could you just repeat it for us, please?
Yeah, so sorry about this audio situation. Basically, there's a lot of apprehension about getting Ayush professionals involved in medical care beyond, their particular remit. And there are things from people asking how they can actually work out. So I wanted Dr. Clare and you to answer this, but I think Dr. Clare is not on it. So if you can anyway take into consideration those criticisms that come from other systems of medicine and respond to that.
Okay, I think Dr. Clare is here, but I guess he's away. I can see him, but I can't. I can see his screen, but maybe he's away. Okay, so there is concern, and certainly there are people who are not as competent. You are correct. But there are also MBBS people who are not as competent. So a credential in India does not equate to competence. In America, we have to take licensing exams just to be able to practice. And then every 5 to 10 years, we have to take competency recertifications. In India, you don't. Once you sign up, you pay, I think it was 40,000 rupees. You're registered for life and you're an MBBS or you're a physician. So there are problems with competence on all sides. So if you take the million of the modern allopathic doctors and you take the 600,000 Ayush doctors and you put them all through a course learning about the basics, and you make all of them train, some of them will very quickly show their competence and be done. The rest of them will get trained. Some of them will be able to finish it in 1 month because they have such current experience. Some of them will take the full 6 months to show competency. But if you do that, not only are you investing for COVID and for treatment in this time, but you're investing toward a group of medical professionals, for right or for wrong, who are already credentialed as medical professionals in India, in any of those 8 systems that I mentioned. And so that kind of a move would invest toward competence. And I think competence is the thing that Niti Aayog keeps talking about, but every document that I'm seeing of theirs doesn't really show how they're going to do that competence. And the way is clinical training. So my feeling is that the IMA versus Ayush is a political issue. And it's partly funded, from what I've heard, because I was looking to get a seat sitting around the ICMR. They said that you have to be purchased by one of the pharma companies in order to really participate. And it seems that most of my friends who are in the, the biopharma-based allopathic system are really backed up by pharma, some company. And so it's hard because the Ayush professionals don't have that kind of a way of thinking. The dharmic part is there are some really good MBBS doctors. I am, I bow to them because they are so good. They really, I've seen them in the MBBS side. I've seen them in the Vaidyas, the BAMS graduates. How do you distinguish them from the others who are just doing it because they want to make money, or they just want a job, or they want the prestige? This is one of the central questions that we have to get into, rather than saying, well, IMA says that they are not competent. Test them. There are people who are really, really great at seeing patients. Why should they be discriminated against just because they trained in homeopathy or Ayurveda? That's their competence. The second part is the philosophy, which is the big problem. There are many people in India that absolutely swear by homeopathy. There are many doctors in India who think that homeopathy is terrible, it's all quackery, and they think it should be banned. And when you have people that don't have a respect for looking at clinical evidence and disrespect that there are patients that really say they got benefit, those doctors that say they will disrespect need to reconsider how they can just disrespect a science blindly. So I just want to throw that into the discussion.
Thank you. That really helps. That's a very logical way of looking at this situation, which is actually quite complicated for a lot of people. Dr. Awasthi, maybe you can also just come in on that, because you had raised that point as well in agreement with Dr. Bhattacharya. Is this a practical way to go? Do you think we'll be able to make this happen? Are there any safety checks we need? What do you think?
I would say that there's a lot more to public health than just prescribing medicines. And, for example, I'm trained as a dental surgeon, and I used to specialize in the area of oral cancer. Now, the biggest help that a clinician or a community health worker can do is to really screen for oral cancer or precancerous lesions. Now, this is something which an Ayush practitioner can certainly be trained to do, may in fact be overqualified to do. So not everything is about, really giving general anesthesia and splitting open a human body. There are, of course, surgical competencies that you need and, that need to happen in a particular L3 facility. But there's so much more, whether it's vaccination, whether it is public education, behavior change communication, screening for cancers, referrals. There is so much that Ayush professionals can do given the big health workforce they are. And a second point I'd like to make, which is probably I may have a personal bias. I've seen so many of my colleagues, my doctors and dentists, who studied from government medical colleges and are now all sitting in the US and UK. And of course, the monetary aspect is so important. It works for a lot of people. But I would say that somewhere, some sort of compulsory, I would use the word compulsory, at least a 6-month rural internship is something that every person, every government medical college graduate can certainly sign up for. Of course, the government will have to look at some sort of a stipend, and for women, security and basic infrastructure and toilets will have to be looked at. But this is the kind of commitment that all the Delhi, Bombay graduates like me really need to be put under.
Wonderful. Thank you so much. And I want to also just thank everybody now for their time on a Saturday evening to prepare for
I think, Anu, you are muted.
Oh my gosh, I gave a whole speech and I was muted. Yes, that I will start my speech again. I was saying thank you to everybody for being here on a Saturday evening. And I think there are many more things that we can say, but these are conversations we'll keep having. So I will just hand this over to Abhishek now to close this. And thanks all of you guys. I think a lot of us are on Twitter. So find us on Twitter. We'll stay in touch.
So So I would now like to invite Mr. Pratish Prabhakar, founder of Community, to deliver vote of thanks. Mr. Prabhakar, if you can join us.
Hello, good evening, everyone. It was a very insightful session on public health and issues around public health, which has been necessitated by the COVID-19 pandemic. And as we can see, the COVID-19 pandemic is not only it's a struggle and it's a tragedy, not only at a personal level, but it has also brought the concerning issues around strengthening public health in focus. And it is the right time to discuss how we can move forward by strengthening public health and taking care of the health of our vast population. So this session was really very timely and relevant. And I thank all the experts who joined in with their insights. With the first step towards improvement is to analyze the constraints. And as we can see, all experts who joined in came forward with discussion around what are the constraints in the current system and how we can improve them going ahead, and how we can have a more strengthened public health system in India. It was a very well-rounded discussion, which involved almost all of the aspects around public health, whether it is about human resources, whether it is about financing public health, or is it about behavior change, or in fact role of alternative medicine and how to have an integrative approach towards strengthening public health infrastructure and services. So I thank everyone who joined in, who pitched in with their comments, who pitched in with their insights, and who also transcended political and professional divides and took a very holistic and a very, I would say, a helicopter view of the public health system in India and how we can analyze the shortcomings as well as suggested what can be done to rectify it and strengthen it so that a tragedy like this does not reoccur. Thank you everyone again, and I thank all the audience who engaged very actively, who listened to the insights, the thoughts of the speakers, and who also pitched in. I can see from the chat box that people have been very interested in putting forward their questions and their remarks, which shows the interest public health is attracting these days, and this session also attracted. And as Anu said, it's a Saturday evening, and even on a Saturday evening, we are not only sipping our evening coffee or tea, but we are discussing very relevant issues around public health. So that's pretty much, and thank you again, everyone. And I would also like to congratulate Abhishek, and going forward, I would like to see more initiatives by Policy Metrics around public health, I'm sure.